Assalamu alaikum and good morning, and again, thank you, Am, and the group for inviting me. The reason I chose this subject, as they say, it's getting more common now in our practice to see patients with high PTH. For whatever reason, for the last 4 or 5 years, we're getting 1 or 2 cases at least a week referred to us for high PTH. A primary care physician ordered it for whatever reason. I think one of the reasons is Dr. Google. People search and they found they have low vitamin D, and then it says order PTH, and they ask the doctor to order PTH. So today I will go through if we get a high PTH, what we should do, and then when we should refer people to endocrinologist. I have no disclosures. This is my outline. We'll have an introduction. We'll talk a little bit about the pathophysiology and then the epidemiology and the clinical manifestation of normocalcemic primary hyperparathyroidism. Then how do we do evaluation and management, and then summary. This is when in 1952, when they discovered, someone did an autopsy on the rhino and they found there's a parathyroid gland in London Zoo. So that's why I put this graph. I find it interesting. As we know, parathyroid consists of 4 small glands behind the thyroid, and they produce parathyroid hormone. If the parathyroid hormone goes up with high calcium, we call it primary hyperparathyroid. And if the calcium is normal, usually we call it secondary hyperparathyroid. If the patient have high PTH with high calcium in severe kidney disease, typically in dialysis, then we can say this patient have tertiary hyperparathyroid. And we know primary hyperparathyroid is a common endocrinology problem we face in our practice. This slide presents the prevalence of primary hyperparathyroid before 1970-75. Patients used to have blood tests according to their complaints, so specific tests like calcium alone, kidney alone, sodium alone. But after 75, automated systems start showing up in the picture, and patients start having routine blood check for calcium, and that's why the prevalence went up almost 3 times. Before the automated system and then after the automated system. And also you can see here is also much more common in females than in males. Now, according to the 5th International Workshop, the clinical phenotypes of primary hyperparathyroid are 3. Number 1 is symptomatic primary hyperparathyroid, in which they have usually skeletal and kidney involvement. And then we have asymptomatic primary hyperparathyroid, whether they have organ damage or no. And then our topic today is normocalcemic primary hyperthyroid. And this is our talk today. So when we talk about someone came to you with normocalcemic hyperparathyroidism, which means normal calcium with high PTH, it could be usually one of 2 things. Either the patient is having a normocalcemic primary hyperparathyroid, in which they have persistent elevation of PTH with normal total and ionized calcium, usually because of adenoma or multiple gland adenoma or hyperplasia. And the other one is usually what we call secondary hyperparathyroid, in which the patient usually have elevated PTH with normal but sometimes low calcium because of physiological stimulation of PTH, like low vitamin D. Now, what is the etiology of normocalcemic primary hyperparathyroidism? It's usually similar to patients with the classic form of primary hyperparathyroidism. It can be a single adenoma, it can be multiple adenomas, or it can be multiple gland hyperplasia. Actually, several studies done and showed these patients who have normocalcemic primary hyperparathyroid have more tendency to have multiple gland disease rather than single gland disease. So what is the pathophysiology? It's still unknown, but there are multiple hypotheses out there. The most common one is it's an early stage of primary hyperparathyroidism. Actually, Zapata have a nice cartoon here. He described the primary hyperparathyroid in 4 phenotypes. Phenotype 1, in which the patient have still subclinical picture. They have a slight elevation in PTH, a slight elevation in calcium in the normal range. So we don't know if they have it or no. They are normal, but in the higher range. And then the phenotype 2, which is our topic, normocalcemic primary hyperparathyroid, in which the PTH become above normal, but still the calcium change in the normal range. And then phenotype 3, it may progress, they become hypercalcemic with hyperparathyroid, but they are asymptomatic. And then phenotype 4, in which the patient become symptomatic. Another theory is hyperparathyroidism of aging. For example, Najjar in 1994, he found that older patients tend to have higher PTH. So could be the cause of this elevated PTH. Another theory is these patients have true primary hyperparathyroid, but their production of PTH is lower than the classic form of primary hyperparathyroid. So they're producing it at less level than the classic form of primary hyperthyroid. Another theory is relative hypercalcemia. What do I mean by that? For example, let's say the patient have normal calcium at 8.5, normal. So their calcium, when the PTH goes up, it goes up, for example, to 9.5. It's still in normal range. So when you check the patient, they still have higher calcium level in the normal range with high PTH, what we call relative hypercalcemia. Another theory is partial PTH resistant at the kidney and the bone level. This is one of the theories. Another theory is vitamin D, which we have talked about this morning. They said patients tend to have lower level at free vitamin D, though they have normal total vitamin D. Finally, some people suggest they may have abnormal in the calcium sensing receptor issue. So they have producing higher PTH than normal population. Okay, what is the epidemiology? We don't have exact numbers of the prevalence or the incidence, part of it because the studies which were done are small in nature. We don't have large-scale studies to give us a clear cut of the number of patients who have this disease. But the prevalence can be varied from 0.2 to 9%, even some of them as high as 17%. Recently published study found that in patients who have primary hyperparathyroid, almost 16% of them, they belong to this group, the normocalcemic primary hyperparathyroid. And the reason for this big variation in this prevalence is multiple. Some of them we don't have we lack really large studies to look at the prevalence. Also, the range of the PTH we know is follow the Gaussian distribution curve. And if you follow that, the last 2.5% of this curve is usually high. So 2.5% of the population tend to have high PTH. Also, in these studies, which we look at the prevalence, they use different values for vitamin D and different values as a cutoff for kidney function. Some of them use the value of 20, some of them use vitamin D level value of 30, kidney function 60, some of them use 40, so they don't have exact cutoff value for the vitamin D and the kidney function. Also, the accuracies of the PTH assays, different assays have different accuracy rates, so different assays are used. And some of the studies also, they use the total calcium, and we know in this condition, sometimes only the free calcium is elevated. And we know, in practice, it's difficult to order PTH if someone have normal kidney and normal calcium. Insurance or people will not pay for it. And also a clear referral bias, because most of these patients which are studied, they already have a primary defect, and that's why the PTH was checked. It's not the other way around. Most of these patients, they have already osteoporosis, osteopenia, have osteoporotic fracture or kidney disease, and that's why the PTH was ordered. So there's a clinical referral bias here. So what is the clinical picture of normocalcemic primary hyperparathyroidism? We can divide the clinical picture to two parts. The classic picture and then the non-classical picture. The classic picture usually we talk about the skeletal system and the renal system. Again here, remember the referral bias, because most of these patients had these conditions, and that's why the PTH was checked. But though they found kidney stone is higher, osteoporosis and fracture are higher. For example, this summary of this analysis on the right in the table, they found osteoporosis can be as high as 57% and kidney stone as high as 36%. What about non-classic symptoms? The evidence is inconclusive. For example, a study found that these patients have higher atherogenic lipid profile, they have higher blood sugar, fasting blood sugar, and higher BMI, while other studies found no such relationship. Another study found these patients have higher fasting sugar, but normal A1C and normal insulin sensitivity. Another study found these patients have a higher rate of coronary artery calcium score, which reflect probably coronary artery disease. So really the data for these non-classic symptoms are inconclusive. So we should take each case separately. So what about the biochemical course of these patients? Again, we don't have strong data to support what will happen to the patient. But what they found, a fair number of these patients will progress to hypercalcemia, another fair number of patients will normalize. For example, Trojan, he followed 20 patients for 4 years, and none of them become hypercalcemic. On the other side, Low, he followed 37 patients. 7 of them become hypercalcemic within 3 years. What he noticed here is really interesting here. Patients who have high baseline calcium are more likely to become hypercalcemic, are older age, and have higher baseline urine calcium. So these are the typical patients which can progress probably to hypercalcemia from this population. And almost more than 40% of his patients developed either hypercalcemia, hypercalciuria, osteoporosis, or worsening kidney or kidney stone formation. So how do we evaluate patients with normocalcemic primary hyperthyroidism? This disease is a disease of exclusion. We need to rule out secondary causes of hyperparathyroidism, because we don't send someone to parathyroid surgery if we decide for it, and the patient has secondary hyper. So we need to rule out secondary hyperparathyroidism. And also the disease have to stay for a few months, and for a few months with high PTH and normal total and ionized calcium. And also we need to rule out secondary causes of hyperparathyroidism. It's very important. Some authorities even, they suggest, because of the assay accuracy, to do 2 different assays. If one of them is normal, then this patient is normal. And also remember, once you confirmation of primary hyperparathyroid, you have to follow the same guidelines as the classic form of primary hyperparathyroid. So really it's very important to exclude the secondary causes. Now, in the secondary causes, typically what we see, the calcium usually is normal, in the low range of normal, and usually these patients probably have vitamin D deficiency or CKD with a GFR usually below 60. These are the typical causes of vitamin D. Typically, we see it usually in patients who have CKD, vitamin D deficiency. Now it's much more common. We see it in bariatric surgery. A lot of them, they have high PTH and low vitamin D. Idiopathic hypercalciuria, medications, remember, the one we use for osteoporosis can cause a little bit elevation in PTH, especially at the beginning of the use, like bisphosphonate and denosumab. Remember, diuretics, SGLT2 inhibitors can increase PTH. So keep this in mind when we evaluate patients with high PTH. Now, imaging. Once we have confirmation that the patient has normocalcemic primary hyperthyroidism, then we need to do imaging for 2 reasons. 1, to look for an indication for parathyroid surgery if we are planning for that. 2, to look for the complication for the parathyroid, for hyperparathyroidism. And if you are planning for surgery, we need to look for localization. Typically what we order is DEXA scan, including the forearm. This is very important because the normal order in the system, when you order DEXA scan, does not include the order. So make sure you add the radius when you order DEXA scan. Otherwise, we cut only the back and the hip. And you need to do VFA spine assessment for fracture, and usually look for renal stone evaluation. But usually, typically, we order renal or KUB ultrasound to make sure the patient does not have kidney stones. So to summarize, the first thing we need to confirm persistent elevation of PTH with normal calcium. Then we need to rule out vitamin D deficiency, drugs that cause elevation in PTH, hypercalciuria, GFR, low GFR, and malabsorption. We have to evaluate all of these. If the patient have low vitamin D, we supplement them, and then we follow vitamin PTH. It can take actually sometimes 6 months to 1 year for the PTH to normalize after you normalize vitamin D. Drugs, if you can stop it and repeat the test, will be good. Hypercalciuria, sometimes we give them what we call a thiazide challenge. I will mention this later. And then if you have a CKD, sometimes a trial of active vitamin D 125 will be helpful. And then if malabsorption, then you treat. If the patient PTH remains increased after you normalize all of this, then you can say this patient has normocalcemic primary hyperparathyroidism. If the patient becomes normal, then this is secondary hyper. If the PTH improves but remains slightly elevated, you have to reassess yourself. And keep in mind, in this case, it could be high PTH because of aging. So we have to assess the calcium intake, the vitamin D, the malabsorption, and then high PTH because of aging. Now, what is thiazide challenge test? If someone have hypercalciuria, one of the treatments we offer usually, we give them hydrochlorothiazide, because hydrochlorothiazide It increases reabsorption of calcium and decrease excretion of calcium in the urine. So what we do here, we give the patient calcium 50 milligram hydrochlorothiazide, for 3 weeks, and then we measure urine calcium and PTH after that. Normally, if you have secondary hyperparathyroid, your calcium will be normal, and PTH will normalize. And you see urine calcium is decreasing. In patients who have normocalcemic hyperparathyroidism, probably they will become hypercalcemic, and the PTH will not change. So this can help us to differentiate between if the hypercalciuria because of secondary or hyperparathyroidism. Another test sometimes we use, what we call oral calcium loading test. We give the patient 1 gram of calcium orally, and then we measure calcium and PTH in the blood regularly over 2 hours, like every half an hour or so. And then typically in patients who have primary hyperparathyroid, there is minimal suppression of PTH, while in secondary causes, because you give high dose of calcium, they will have marked decrease in PTH. So if you are in doubt, we can use this. It helps us differentiate which route, which is your diagnosis. I use this a few times, but I never use this so far, but keep it in mind, even though there's no big data supporting these, especially the second one. Another interesting one people start talking about is the parathyroid function index. This is recent data published by Wang. What they look here at the parathyroid function index. The idea behind it, because if someone have primary hyperparathyroid, typically they will have high level calcium, even in normal range, and normal and low phosphorus. So if you divide the calcium multiplied by PTH divided by the phosphorus, you will get a higher number, because you will have higher calcium and lower phosphorus. If the value is over 34, it suggests this patient have normocalcemic primary hyperparathyroid rather than secondary hyperparathyroid. But still, this needs to be probably to be validated with a bigger study, because this study I think was small, but it's a good way of doing it if you are still in doubt. So how do you manage these patients? As we know, classic primary hyperparathyroid, the management is either medical or surgical, and we have clear guidelines when we send the patient for surgery. In these patients, there is no specific guidelines, but probably we follow some of the guidelines as an indication for surgery. So the treatment really, which cured the patient, is really parathyroidectomy. If the patient does not want surgery, or if the patient is not candidate for surgery, then medical treatment is an option for these patients. So what we advise them usually to have some calcium supplement between 1 to 1.2 grams daily to normalize their vitamin D, to keep it in the normal range. And for example, Cicero, he did a study, he gave the patients alendronate. What they found, the BMD improved significantly after 1 year. So one of the options of treatment, especially if the patient have osteoporosis, is to give them bisphosphonate. Now, how do we monitor patients if they decide to stay in medical management? You need to do annual calcium, total and free, PTH annually, DEXA scan every 1 or 2 years, including the forearm. And if suspect of kidney stone, you need to do probably KUB ultrasound. And then if suspect vertebral fracture, VFA or spinal X-ray to rule out fracture. So they need long-term follow-up and monitoring. Now, one indication of surgery, kidney stone, fracture, worsening BMD or osteoporosis, or during follow-up if the patient becomes hypercalcemic, then in this case we follow the guidelines. In the classic form, age is one of the indications. Here, the data is limited, so we cannot use probably the age as an indication for surgery in these patients. So what the problem with surgery? You know, it's easy, you take it out. The problem in primary hyperparathyroid, localization and imaging is much less than patients who have a classic form of hyperparathyroid. For example, here, one of the studies found out ultrasound was 22% accurate versus 58% in the classic form. System EB scan, 11% versus 75%. The parathyroid CT scan, 55 versus 75%. So you are less likely to localize the disease. And this is important because if you do not localize, you end up not doing a minimally invasive procedure, you will do more exploratory, more invasive parathyroid surgery. Also, these patients tend to have multi-gland disease, and that's why they end up having more bilateral exploration of their thyroid. For example, a study done by Barabandian here analyzed the database of parathyroid surgery. What he found, single adenoma is more common in the classic form of primary hyperparathyroid rather than the normocalcemic primary hyperparathyroid. Also, these patients had a higher rate of subtotal parathyroidectomy, in which they removed 3.5 glands. Also, they found also patients tend to have more multi-gland disease than the patient who have classic form of hyperparathyroid. Again, these patients come to you with normal calcium high BTH, and does it look nice for the patient when you do surgery and their BTH remains elevated? Because there is a good number of these patients, they will remain with high BTH. For example, here, showed the study here, he found almost 46% of these patients will have persistent BTH after surgery. So that's why we have to think twice, maybe thrice, before we decide to send the patient for surgery or no. Another literature review by De La Plaza here, he found this prevalence of elevated PTH after surgery can be as high as almost 24%. So, if the patient, you think they need surgery because of kidney stone or high urine calcium, probably a good idea to give them thiazide and see how they do. If they're improving thiazide, maybe they continue thiazide and you can save them a surgery. Another thing also, if the patient have osteoporosis, maybe if you give them bisphosphonate and you follow up, if they improve in bisphosphonate, you can save them surgery. So before you send them surgery, people, please think about this as a treatment choice before sending this patient for parathyroid surgery. So to summarize, the first thing we need to have biochemical diagnosis of normocalcemic primary hyperparathyroid. We'll do imaging, looking for complications. And then if the patient have a strong recommendation for surgery, which include kidney stone, fracture, worsening osteoporosis, or if the patient is going to have thyroid surgery for thyroid nodule or whatever, then you can send them for surgery. In this case, we need to do at least 2 imaging. Typically, they prefer system EB scan and ultrasound. If both are positive and concordant, they locate the same place, the adenoma or the abnormality, then you can do for the minimally invasive procedure and intraoperative parathyroid hormone level. If one of them is negative or they're not going together, then in this case, we have different options. We can do 4D CT scan or choline test, PET scan. If you cannot do this, then you have to do exploratory parathyroidectomy. And then intraoperative parathyroid level. Typically, we like to see the parathyroid hormone intraoperative to drop more than 50% to say that the procedure is successful. In patients who have, you plan to follow up, remember annual calcium and parathyroid and kidney function and DEXA scan every 2 years, and then maybe renal ultrasound if needed. If the patient become hypercalcemic, then we have to follow the same guidelines, hypercalcemic primary hyperparathyroidism. If the patient symptoms develop osteoporosis, develop fracture, worsening osteoporosis, or kidney stone, then we can decide for parathyroidectomy. So in summary, remember, normocalcemic primary hyperpara is a diagnosis of exclusion, is a biochemical diagnosis. It usually over 3 to 6 months, you have to have elevation of PTH with normal total and ionized calcium. Make sure you order ionized calcium, and you need to exclude secondary causes always. And we don't know the natural history still because the studies are small and few. We need probably more large data studies, and the data for the best management is still lacking. So please think twice if you are planning to send the patient for surgery, because you don't want to end up having surgery and the patient is not cured and they come back to you upset or mad. Thank you.